Thanks for joining us to talk a little bit about mental health and the digital universe. My name is Robert Garber. I'm a partner at Seven Wire Ventures in Chicago, where we focus purely on investments in digital health with a particular focus around how do we make life better for the consumer as opposed to how do we just solve problems for payers and providers. Still investing mostly in B2B companies, but really with the focus of improving the lives, information, tools, technology, and access for us as participants in an increasingly retail-driven healthcare market. We're lucky to have 5 great panelists today. Let me let them introduce themselves. We'll start with you, Justin, and then we'll delve in.
Great. Well, my name is Justin Baker. I'm a psychiatrist and neuroscientist over at McLean Hospital, which is just west of Boston. I am the scientific director for something we call the McLean Institute for Technology and Psychiatry, where we work with both clinicians, researchers, and also industry partners to try to find better solutions in mental health. I also run a small lab where we use a variety of digital methods from computer vision to neuroimaging to both study patients with schizophrenia and bipolar disorder, but also try to develop some new treatments. Thanks for inviting me to the panel.
Thanks, Justin.
And I'm Vic Lanio. I'm a venture investor at Flare Capital Partners. We are based here in Boston. Generally speaking, we're Series A, Series B investors, but we maintain some flexibility on that. We're also focused on digital health, healthcare IT, and tech-enabled solutions. So a lot of our investments are very service-heavy. And I kind of like the way that you described it. We try to make sure that we're investing in solutions that are helping the consumer, but oftentimes we're going through the payers and employers and providers first. Yeah.
Great. Thanks, Vic.
My name is Brian Mullen. My background originally in mental health technology was my PhD focused on how to design for that, and I spun a company out of that. And thank you. And back in 2008, I ran that for 8 years, and we were trying to provide the first evidence-based insurance reimbursed medical device for people with autism and expand to ADHD, PTSD. So I've gone through a round of raising individual, kind of more friends and family round, early AA round investment back in 2009, 10, 11. Tried to raise another round of funding in this space and learned how hard that is. I won Mass Challenge 2011 for a $50K award. So I have a lot of experience of trying to start a company and raise money. Now I am working on legislation to support innovation in mental health by the state because I think there's an incentive for them. And then at Brigham, my day job now is to, I work at the Brigham Digital Innovation Hub. So how do we support and advance digital innovation at Brigham and Women's Hospital, which is a large academic medical institution here in Boston. We're part of Partners Healthcare. To give you a sense of size, we do about $500 million in NIH-funded research and sponsored research agreements. So we're a large academic medical institution. We look at how to help innovation ideas move out of the hospital, but mostly hopefully find what these guys are working on, and hopefully they're funding some stuff so that they can actually early on work with us as an institution so we can consume better digital innovations to provide and deliver better care to hit the quadruple aim. So our passion is delivering better care and better experiences for our doctors, our patients, and better outcomes. And we think that digital innovation and all of the work that we're doing in their portfolio companies is going to be where it's at. So almost all our effort is collaboration with early stage or industry.
Great. Thanks.
Hi, I'm Ellen Herlocker. I'm director of Tufts Health Ventures here in the Boston area. We're the corporate venture arm of Tufts Health Plan. The health plan operates in all markets across a few states in New England. We intersect with behavioral health in that it's a huge pain point in terms of managing the variety of conditions across our population, and it's also one of a few focus areas that we've identified in terms of investment. In terms of what we look for, we're looking for strategies that appear to be effective in lowering the total cost of care, in producing better outcomes, and then also expanding access.
Yes, I feel after such a good panel. Good afternoon. My name is Clement Cazot. I'm the managing director of Techstars here in Boston. We are a pre-seed to Series A accelerator focused on technology in general. Naturally, being in Boston, focused on digital health a lot. We've helped over the past 9 years 148 companies in the Boston area, 1,300 companies globally. And mental health and behavioral health is naturally one of the areas in the digital health that we're looking at closely. Only last year we were already invested in 2 companies, Sophia and Bureau System, focused on this area, and historically had started to help a company called Ginger.io back in 2011 doing early bets in this area. So really excited to see from you guys what are the questions.
Great, thanks, Glenn. Thanks, everyone. So mental health's a big area. I know we use this term behavioral health as sort of a catch-all. I mean, it could be depression, anxiety, it could be eating disorders, it could be substance abuse disorders and opioids, it could be personality disorders. I mean, it's a big melting pot, lots of problems. And there have been lots of companies thrown at these problems over the last couple of years. So let's start with an easy one. So what's working and what's not with the application of technology to behavioral health? Because I think there seems to be an imbalance between the investment that's been made in digital health today from a behavioral health perspective and sort of the outcomes that have been derived. So maybe Alan, since you're both on the clinical and the investment side, maybe we'll start with you. I get your perspective since you can see it.
Yeah, that's a tough one. So if you look at our portfolio of behavioral health investments, it's 0, and so I think that may be exemplative of, it's not that nothing's working, but it's that it's maybe not solving all the challenges that we're looking for, and it may be one of the things that we struggle with is that we'll see interesting solutions that appear to solve some type of problem, but that maybe the benefit doesn't necessarily accrue to a payer. So some of the digital platforms, there seems to be a space that's fairly well populated, which is these kind of emotional support digital tools that appear to be effective in terms of expanding access, in terms of improving the wellness of the people that they interface with. But the benefits often accrue to, for instance, an employer who sees lower turnover, higher productivity, higher engagement across their population, but not necessarily a payer who's looking to really drive down the total cost of care. So right now, we're still looking for that unicorn. We think that there may be some interesting ways where there could be digital solutions for some of the more complex problems, with substance use disorder in particular. We're not necessarily convinced that a digital solution could solve the entire problem, but there may be pockets of the problem where a digital solution would be helpful.
Clem, how about from your perspective, since you've made some investments in the space?
Sure. So what we've observed, and when we met this, keeping in mind that we're pre-seed to Series A stage, so betting early in these founding teams that are passionate about the problem and will find a solution to square with that, is the digital piece only is not covering the solution. That's just part of companies that are trying to reinvent. You mentioned all these apps that are going on the emotional support are great tools that are complementary to an existing chain of values that exist in the ecosystem. So what we've seen is companies that are additive to existing practice are great. People who are trying to replace therapists. That's a trend that we are seeing with trying to get these apps that are literally replacing entire part of the support system that is already put in place, or going or hard because not adopted by the payers already. So what we're seeing is company on the innovation side that are adding, removing some of the stigma that are existing in the space are the ones that are the solution that seems to stick the most, both on the payer side and also with the recipients and the users.
So Vic, how does what Clem is saying tie into sort of some of your services-heavy businesses where you see that behavioral health is really a combination of tech and touch. And perhaps we're trying to figure out right now what the right balance is so that we create scalable models. But the reality is as Ellen said, that technology is a piece of the problem. So how do you guys think about it as you're looking at solutions out there and thinking about, you know, we still need, we're humans, we still need the human element, but we have these technology tools that make sense, but sometimes it looks like we're throwing technology at a problem, you know, hoping that it works, and it may not be a good fit.
Yeah, and so of our current portfolio, the one company that has a more heavy behavioral health component to it is Iora Health, which is a primary care model. And so what they do is they integrate behavioral health with primary care, and so it's actually not a tech solution at all. It's, you know, just embedding therapists into primary care in a way that it does reduce some of the stigma of, you know, the patient doesn't necessarily feel like they're going to see a psychologist or psychiatrist. They're going to their PCP and also getting therapy while they're there. And so from, you know, that perspective, these collaborative care models are pure services, but they're you know, allowing patients to access behavioral health that might not otherwise not.
So last week when we were preparing, Brian, you mentioned something which I thought was really interesting, that part of the problem is a lack of innovation, is that all we're doing is taking existing offline models and putting them online. And that doesn't exactly look like innovation, it just looks like technology. So talk a little bit about how we should be addressing this, or how you think we need to be thinking about, you know, changing the way we are treating certain, you know, behavioral health elements, and, you know, how do we stoke this innovation? If there isn't enough innovation going on, let's first address that. Do we believe there's enough innovation going on? And if there isn't, then how should we be thinking about this differently?
So there isn't.
Okay.
I mean, you know, 4 years ago I sat on a panel for autism, and a psychiatrist got up there and said, if you took a psychiatrist from 50 years ago and looked at the list of drugs that we have for all of psychiatry, they would be able to prescribe 99% from the chemical composition. Because we basically don't have any new drugs, really new and novel drugs for all of psychiatry, let alone, so we're not innovating in the drug sphere, where that's probably the most innovative spot that makes the most financial sense, right? So technology, until the reason why we have this panel, if you look at this is probably the first investor panel for mental health I've ever heard of. There's only one other. There was one for autism in 2010 or something like that. 11, I was on that one too. That there is zero, because the Affordable Health Care Act is why we're having this conversation. The Mental Health Care Parity Act and the Affordable Health Care Act, and why it matters is because now it's a cost that people have to worry about, that we have to account for. Before, it was a cost center, and we're just hoping to cover whatever legally was required. So there was no incentive to put innovation into it, because you're already losing money in psychiatry and mental health. It's a money loser, not a profit gainer, right? That's the nature of our healthcare. So there's been essentially $0, and, you know, even here with this panel, that's the cutting edge. No, there hasn't really been major investments, and if you're not investing, that means there's not innovation, right? Cash is king. Cash dollars going to the marketplace. 10 times more money goes into cancer than all of psychiatry. So if you think about where cancer is today, and, you know, 30 years ago, 40 years ago, people told me cancer is where that was 40 years ago was a stigma if you had breast cancer or a cancer. It's like, oh no, like you don't even talk about it. And now today you can take a biopsy of the tumor, genetically sequence that tumor, and then deliver a drug specifically tailored to that genetically sequenced tumor type, right? It's no longer even organ-based. We are not even close to that in mental health, right? What we're doing actually is probably closer to, we have a problem with access. How do I just get over the fact of stigma and getting somebody to talk in Iora Health, which is novel and great of a service innovation, but we're still looking at how do we just get people to service. And then there's a whole sense of discovery that we need to do to understand these disorders, measure them, monitor them, treat them, and think novelty. So we're not just taking CBT, which has been around forever, and putting it in an app so that it's a little bit easier to do CBT. So we're doing incremental stuff, but I think the thought of doing that is a bigger stuff and being more novel. Is we're just at the starting point of what we can do for mental health, and it's the biggest problem of our time. It is the biggest unmet medical need by every measure you can have. and we're just not innovating, we're not putting capital behind it, and we're not taking bets, and it's for a whole host of reasons. So it's new, and we need to learn about it. I hope that answers your question.
Yes, I agree with everything that's been said. I think, we were certainly seeing the case like Ginger.io, where, you have a relatively simple platform, but there was really very little incentive to get providers using that because it didn't, work with the workflows. And until you're in a capitated system where you have to drive costs down, it's really just adding to providers' workflows. And so we saw that a lot of the players who were trying to make somewhat radical moves were not doing it with any understanding of those workflows and needs. So even if a patient was really asking for something, providers were like, that's a non-starter to give me, that patient that much access. And so I feel like I've been kind of watching along the last few years, and it seems like this is one of those things that people have a really hard time just getting their head around what it even means to provide good quality mental health, behavioral health care. So you have a lot of computer scientists, engineers, people who are used to starting other kinds of healthcare companies coming in and say, okay, well, let's just take the cancer model, apply it here, that should probably work. Of course, that's really not a great way of thinking about mental health care. I personally like the idea that, in the computer software world, we're all used to the idea that Apple and Google and other software providers are increasingly providing us, better and better user experiences, which is in order to optimize our behavioral, our behaviors more globally, right, in our lives. Those user experience experts are much closer to designing tools that look like what you would want in an optimal mental health care system. And yet they're more about performance enhancement, kind of efficiency and things like that. A healthcare company trying to come in and replace what Apple and Google are best at is just not, it's not going to happen. But being able to look at the mental health care system as it is and trying to kind of work backwards from what really does work well when it's working well, and how do we scale that? How do we take what the best human experts are able to do in the context of some kind of evaluation for more severe mental illness, but also how to do triage and all these kinds. I think we'll see that a lot of that kind of expert logic will be able to build more and more into software and hardware solutions. But I agree, it's just there's sort of a culture clash. It's been slower than I would have liked to see those two cultures really merging and trusting each other and being able to kind of share insights and needs in a more kind of honest and joint way. But
let me perhaps share, we all have a dark view of that space, so let me share, decipher why we made that bet, decided to bet that, because we believe that as a society, we're extremely good at creating demand for behavior, for mental health right now. That's something that is universally understood. What we are betting on is that actually the access, the democratization of mental health, removing the societal stigma that there are around, is actually the first key to unlock innovation. Right now, there is, if you look at the subset of the population that should access care and the one that access to engage actively in care, you have a ratio to 1 to 6. Only 1 in 6 person that should be treated is treated or is actively engaging with this type of treatment. So the innovation that we're seeing is through applying all the digital marketing education that you're seeing to actually bring more people into the system and bring more people at the bottom of the system, creating more value. Therapists right now, there is an entire discussion that you have a radical shift between the high end and the low end, people going in network versus out of network and out of pocket. There is a radical difference in terms of financial incentive, from people paying $50 a session to $250 a session to $400 a session. That's where we see innovation right now, because as there are going to be more demand, that's going to generate more revenue in that, and that's going to be an incentive to have more innovation in that space. So that's a positive light that we see people, especially around all the discussion that we have publicly on opioid crisis. There is a global acceptance of our society. What we're seeing right now that works in terms of innovation is more and more startups going through the employers and actually democratizing. You guys are already paying through partners, Blue Cross Blue Shield, through Tufts, through the plan that you're already putting access to these cares. However, your employees do not leverage that. Let's unlock that possibility and let's have a discussion. So one of the startups we work with, Sophia, based in Boston, is currently for one of the top 4 nationwide consulting companies, is covering 4% of their entire population. So 4% of their employees within 12 months are now accessing mental health care, which they didn't before, because they worked on this education. So that's the part that I think that's to your point, Brian, like these are new panels. There is more and more awareness of that, and that's what is interesting in terms of innovation or even investment.
Great, thank you. So you raised 2 interesting points there. One is access, and how can technology be used to drive access. Access also obviously plays into reimbursement, and so you have to look at behavioral health from a socioeconomic perspective and who has coverage and who doesn't. And then the other one I'm curious about is if we're successful at using tools to surface the underreported behavioral health, mental health issues in the country, which are widely reported, we have probably an even bigger supply and demand problem than we have in primary care. And that we simply don't have enough professionals to service that population. If everybody raised their hand who had a mental health issue and said, I need help, we'd be in big trouble.
So it's 25% of the population.
25, yeah.
At any given time.
So how or if can technology help address that? Because I know everybody sort of talks about wanting to give people, there's parity in coverage perhaps, and now they want to get people into coverage, but then the system will just end up sort of imploding on top of itself if we don't figure out a way to do it in a more scalable way.
So I'll tell you what I testified to the State House on. So I've written legislation for this reason, because I've sat through a few hearings on this because I was trying to, policy really dictates mental health care, right? Most of the care provided in coverage for mental health historically is by our tax dollars. It's prisons, it's schools, it's homelessness, it's Medicare, it's Medicaid. That's where most of the care has traditionally been provided. So the state has, and the government has a big part of this. So I finally realized that after my journey and sat through these hearings, and if you could sit in Kendall or Boston for 6 hours anywhere, you'll hear the word innovation except in a mental health conversation. And the reason is people are asking for more access. They're asking for it. They're asking for better quality of care and services because they're getting minimum adequate care, and most of that is still not sufficiently good. We still restrain people to beds and not have treatment for some of the more severe cases. We board people, just let them sit and wait for periods of time. So if we had infinite number of dollars, we cannot cover the people and give the access. If everyone showed up at the door, we cannot actually give it, and we don't have enough payers, providers, and experts to deliver the care. So the opportunity, and this is why I've written the legislation in my argument, is the only way you increase access, reduce costs, and improve quality, and every other industry does this, is through innovation. So optimistically, innovation in this space is the only way we're going to solve that problem, and we need to actually think about it beyond the current models of a human service provider. Where's humans come in? Understanding that mental health and those disorders are very different than physical disorders, understanding what we need to measure, what we need to monitor, and how we need to intervene. And it's not the same as cancer in any way, shape, or form, or diabetes or whatever else. It's actually a very real-time challenge where you could go hours without having your insulin, but if you have PTSD and walk into a room, you can be triggered instantly. So how do we do that? I think there's a ton of opportunity, but I think we need to think outside of traditional models of psychiatry and psychology and neurology. And most of the care actually for right now is being delivered by parents and teachers and police and occupational therapists and speech language therapists and social workers and prison guards. So how do we actually start to understand what really is the healthcare system for mental health, and then where do we fit in? Because the people who have access to care, it traditionally hasn't been covered by insurance, and it's been a separate insurance, so that's why it's harder for insurance companies. It's a new game for them, the traditional one. So I think there's a ton of, from Iora health models to technology to digital to drug and device, we need to think of all of them, and even government innovation in delivery care. So I think it's very broad, and I think we need to think of it broader than any one given area, that we're so used to in life sciences to be able to have a medical device industry and a drug industry. I don't think that's how we got to think about mental health. It's got to be systemic in multiple tools in the toolbox.
So, Ellen, if you take your investor hat off for a second, put your plan hat on for a second, tell me a little bit about how you were thinking about innovation and the treatment of behavioral health.
Sure. So going back to the question that you just asked around, and I think the question was, how do we cover all of the people that are potentially going to raise their hand if you say who's suffering from some form of behavioral health condition. I think one of the things that innovation can do is maybe make existing therapies work better. This is just one example, and this is not surprisingly our biggest pain point as a plan, but it's substance use disorder. And the problem statement is essentially goes like this. Somebody finally enters into some form of treatment for substance use disorder. They go to a rehab program in Florida that's out of network. If we're lucky, it costs $25,000. More likely, it's more than that. They usually do maybe 4 to 5 urinary lab screenings a week, which pile on additional expenses. And then within a year, the patient still relapses, and so the efficacy is horrific. So I'm not sure what we can do necessarily to make an inpatient rehab experience better. I know there are some things out there like paratherapeutics, but one of the things that I think technology can do is reinforce the recovery post-discharge. And so we're seeing some forms of therapy that are maybe digital and community-based and create some peer-to-peer networks and support systems that appear to reinforce what traditional therapies are doing. And then along those lines, it frees up maybe these more traditional rehab facilities to take on more patients because they're not having to cycle people in and out of these revolving doors. So I kind of go back to, I'm not necessarily sure we can rely on digitization or innovation to box everything out that we know, but I think that it can be used to reinforce things that aren't working perfectly.
Maybe have one example there too. So kind of, expanding on the substance use disorder piece. So in some areas we have clinic-based solutions like groups or Clean Slate or Column Health or things that have multiple outpatient facilities that have therapy, MAT treatments, and but across the country, I think it's something like 80% of counties have 0 prescribing providers, and so there's clearly a top of the funnel issue. And there are forces on both sides where you don't want to create a completely virtual model that just has doctors just prescribing and not really interacting with those patients virtually across states or counties. But there needs to be a solution for these patients that currently have no option. So there's an early stage company in New York called Boulder Care that's working on something like this, where how can you create a virtual model for MAT for these patients that have 0 prescribing providers in their region. And like I said, there are some kind of concerns about how close the relationship is between the patient and the provider. But right now these patients have nothing.
And then kind of going to maybe to the top of the funnel, thinking through how digital tools or innovative influences could be used to curb the problem before it gets bad. So thinking through how technology could be used to control opioid prescriptions in the first place, how they could be used to even monitor injuries before they happen. It doesn't address all behavioral health, and it certainly doesn't address all SUD, but it does start to wick away at what appears to be some of the thorniest problems.
So just on that, at Brigham, we're launching an opioid and pain innovation initiative that has a portfolio of looking at these things, because in the thought of pain isn't just the addiction side, isn't just as part of it. It's systemically, when you come in to get a surgery, you will be in pain. So how do we manage you pre, during, and post? And the goal hopefully is that we've kind of set in that group is in 10 years or less, you should no longer be at risk of addiction or death just because you have pain, right? So, and there's a suite of technologies that these researchers and clinicians are actively working on where they see opportunities of, when you come in the emergency room right now, one is working on a way to actually identify which, if you are overdosed or if it's something else, B, which drug, and then understanding where you are in their progression, because right now, by the time you get a urine test or blood test, you're off, the high is over, and it didn't give you actionable information. To your point, we have another one that's built out a whole coaching model because he is the prescriber and can now support multiple primary care physicians as the prescriber, and he's built out a coaching model to do that. So there's many things that the hospitals are looking at. Internally, this is a problem that they're really actively, the clinicians themselves are passionate about and trying to come up with innovations to do it.
Yeah, I mean, I just sort of agree, like, this is not really an access issue per se, because, you know, we've had anti-stigma campaigns which have really, you know, brought mental health to the public health forefront, and now lots of people are coming out the woodwork requesting services which we have no way to provide without either incentivizing like a whole new generation of people to become trainees and you know, go through all the training you need to become a prescribing physician, or so all of the kind of upskilling models, sort of doing task shifting, whether it's, you know, we all know how to talk to other humans, and so I do think that I find it unlikely in the long run that we would ever move to a full virtual model of providing mental health care, but we can provide a lot of ways to more rapidly train, whether it's that, you know, priests or policemen or other people to have much richer fluency around mental health, just so that it's, you know, whether we are literally training people with, let's say, bachelor's level of education to be able to provide some amount of behavioral health care, which is still being supported by MDs and PhDs, people with additional training. I personally like the dentist model. You know, behavioral health in a lot of ways is more like dentistry. You know, you want to catch things early. You want to get people into the culture of brushing their teeth and engaging in other routines of hygiene, right? And having good practices, whether it's sleep, eating, whatever. There's going to, in my view, you know, in the next 20, 30 years, we're going to see society at large have a much greater fluency around those. What are those things? And I wouldn't be surprised at all if sort of some of the radical shift of how we approach the problem is something much closer to the dentist office model, where you have a single provider with a bunch of people who are, you know, much less training, but that can see a much larger, you know, panel of people, and just see them every 6 months for some sort of checkups that would combine, you know, some sort of digital remote monitoring through an app on your phone, as well as some additional kind of behavioral assessments that you would do there in the office. But still with that one-on-one, you know, you're still in the dentist's office for an hour with a human providing, you know, some level of care. I think if we just go to that part of the dentist visit where you see the dentist for 2 minutes, no one's going to come away from that interaction feeling like they've gotten a quality interaction. But I do think some kind of blend where we start trying to, you know, anticipate models like that and really build out companies and suites of tools that I would say not as much focus on the stigma, but actually focus more on just like the measurement culture. So I think, to me, what's sort of notable about psychiatry behavioral health, having gone through training, is that we don't really measure much of anything. You know, we don't measure the encounters. You're in an ICU level inpatient experience, and you're not getting much of anything measured. You're talking to a lot of individuals, but other than, you know, medical record system, you know, there's very little of that touch that makes it into a system that can then be, you know, interrogated and sort of optimized. So I think the more we can actually get tools that are just sort of blood pressure cuff equivalents for mental health, I don't personally see a lot of progress towards getting to something where we can really upskill and do task shifting without that kind of quantitative backbone.
So you bring up an interesting point. So how do we know if we're doing better? How do we know if we're actually treating behavioral health better? So there are simple situations where you have very medically oriented ailments like schizophrenia or bipolar disorder, where you know that you take meds and people stop having visual, you know, hallucinations and hallucinations, and that's pretty clear. But for the rest of the people that may go up and down, or may have other things that, you know, substance abuse disorder or anxiety that is only provoked in certain social situations, or what have you. If we can't measure it, how do we know if we're doing better? Are we just looking at claims and looking at claims data? Are we looking at absenteeism in the workplace? How do you attribute to mental health versus a number of other issues?
I think you're right. There's no way to necessarily assess whether we are mentally healthier. I think we can look for clues, and maybe some Trojan horses that give us some insight. Are we sleeping better? I think we can use digital tools to measure that. I think we do see lots of evidence of mental health exacerbating medical issues. So we see all the time people going to the ER thinking they're having a cardiac condition and it's a panic attack. And so I think that there are maybe clues that we can look for in things that we wouldn't necessarily associate with behavioral health. But I think that kind of going back to there's not enough innovation, we haven't put enough thought into how we measure impact yet.
Well, the point you just bring up is another one and sort of I want to weave into here and then let you guys weigh in, is sort of the idea of comorbidities. Sort of the idea that either behavioral health can be a byproduct of a physical ailment or vice versa. And so if you look at the occurrence of behavioral health issues, mental health issues with oncology episodes or with congestive heart failure, any of these major chronic ailments, high correlations, very, very high correlations, right? And so the idea of treating a mental health ailment in its silo over here by itself, is an antiquated model. I mean, we have to be thinking more holistically, don't we, about how we treat the whole person and a more integrative model that puts behavioral health in the center of this. And to your point, maybe proactively is saying, look, somebody just got a cancer diagnosis is going to they're going to have some behavioral health issues. Why not get in front of that before you find somebody sort of curled up in a ball in the corner of the room who hasn't left their house in 2 weeks? So how do we think about both your point, which is sort of looking at sort of the way it integrates with physical medicine, and two, also, how do we track, the impact?
I want to talk about, I think in the subcontext of this, that in life sciences, we know a lot about a lot of conditions. We know a lot about cancer, we know a lot about diabetes, we know how these things work, and we understand them, and we can measure them, and we take biopsies and do all this great stuff, and then we have tools to do it. I think one thing that is the challenge in the mental health space is we don't know. We actually don't know. In measurement is an area of innovation, and actually where MIT Media Labs has come up. It's actually where a lot of stuff is. It's looking at in the way we look at the diagnosis is like behavior, function, and physiology. And physiology is actually a fairly new way to do it. And we're looking at a lot of the startups are looking at what's your internet usage and how often you're on Facebook as a way of measuring behavior. And then there's the function, are you showing up to work? That's not really how you would measure anything else in life sciences, and the part of it's just a lack of deep knowledge and understanding. So I think we need to improve that and get better models and do the science and research. When I started my company, I had to read and actually start to do clinical studies to get the information to inform design. And if that's true, that's going to be a hard way to achieve innovation. And then I think the other side of this is knowledge, and that's why this panel is so important, is investors and communities and payers all need to understand what the state is today, where we can have an impact, what we can measure, invest in that actively, but also invest in that in a way that allows for getting to the next leap in innovation. So I think that's a big underlying issue of your question of really what do we know, how do we then measure it and monitor it, but ultimately the comorbidity thing is, and why again we're having this panel, is cancer is 3 times more expensive to treat when you have a comorbidity. 50% of people have a comorbidity. If in 40% of the cigarettes smoked are by people with a mental illness. So if you want to reduce cancer rates, treat mental illness, and stop people smoking. When you look at heart failure and other things, help people who are self-medicating through alcoholism or cigarette smoking, because that leads to heart failure, diabetes, and all these things you can't self-care.
I guess I would just add, in my opinion, we actually do know what to measure, and it's just that people don't measure it now. But if you ask, a clinician or anyone who works with patients, is somebody getting better? There's all sorts of things you can point to. And I guess my perspective, coming from a motor neurophysiology background, would be behavior is really no different. And now with the technologies that are out there, measuring people's physiology through an Apple Watch, whether you're getting the PPG sensor to get the heart rate or the accelerometer to look at their behavior, the same math, the same basic approach. If you're not isolating behavior over on the side, it's actually no different than any other branch of medicine. It's just that for a lot of issues tied in with the stigma, but also just sort of the way that an office looks if you're in the behavioral space versus more conventional medical. We just don't have those kinds of tools at our disposal, but what kinds of things you can begin to measure. It's relatively straightforward to quantify, to begin building ways of quantifying function and people's mood, whether it's using MIT Media Lab and facial expression stuff, or just a whole host of other ways that you can really begin taking all the clinical pearls that clinicians use, some of which are maybe not, based more on superstition, but other ones which are tried and true, and sort of systematically convert those pearls into something like that could be like a closed-loop actionable system. I think there's sort of a whole, garden of potential companies out there that would just take a clinical pearl, find a way to close-loop it, and build it out as part of a larger ecosystem. And I think, to me, that's how we get there. Is just to gradually take clinicians and other people working with other, outside the healthcare system are finding could be leveraged in a tech environment.
So let's go down that thread, trying to pull this all together. So we've talked about a lot of the systemic problems in behavioral health, how technology may be able to apply to it. We need more innovation. Perhaps we need people thinking more creatively about new solutions, how to leverage people up and down the clinical licensure spectrum. So if you're advising companies and figuring out how do we start to chip away at this, what are your thoughts? I mean, I think part of your point, Brian, is it's a big ocean, we can't boil it all, right? So let's think about sectors where there are big problems, but are very discrete. Substance abuse happens to be a very discrete thing with MAT and other types of therapies that are very well defined, and there are obviously other examples in that. But so how do you bring this back down into a practical application and say, what should we be spending our time on in the next year, 2, 3, 5 years, and where we think we can actually have some impact? Anyone?
So this is, an answer, I think, to the question, but maybe a little bit, off mark a little bit. But, so at Flare Capital, we think of behavioral health, mental health, and social determinants of health in kind of like this big spectrum. So in getting back to your question about measuring things, you can measure, reliable shelter, food, transportation. So there are, I'm encouraged by companies that are resolving social determinants of health that are upstream from these downstream mental and behavioral health issues. CityBlock is a great example of this in New York, where they're going into people's homes, or sometimes they don't have them. They're building basically an EHR that can measure the reliable access to these things that you think of, like Maslow's hierarchy of needs. If you have diabetes, you might be primarily trying to get dinner, right, or find a place to sleep for the night. So if you can kind of we think about this, and we're very interested in models where you're partnering with payers to work with populations that need to resolve those things first, and then you kind of set up a risk-based model where downstream you can kind of start to measure the positive impact on the medical and behavioral issues that they might have.
So I've advised people in the mental health going into this, and I'm sometimes jaded and sometimes I'm super optimistic. If I were to restart a company in mental health technology, and this is, I would say, is one of the mistakes I didn't pivot to and should have along the way, is I would do a startup that picked a condition that I could influence. So heart failure, cardiology. I would be doing I think it's able to, that was a cardiology one. I would do something in cancer. We just helped a clinician there launch an app to provide psychosocial support to young adults with cancer. Because then you are doing something that moves a number that people care about today, which is cancer. Traditionally, we haven't cared about mental health care and social determinants. I don't think we're there yet. I think that's a 3 to 5 year bridge to show those things matter and then end up on a line item somewhere in the new model. But we can show that the cancer patient is getting a better cancer outcome or a better lower cost. That's pretty discrete. Same with heart failure, diabetes, and all these conditions. So I peg your mental health innovation to be mental health and supportive, but tie it to maybe depression for one of those things you can actually start to, in the short term, show an impact on a number that is meaningful on a spreadsheet that exists today, that somebody's monitoring historically, and not trying to create a new measure and have somebody adopt a traditional psychological one which they don't understand and can't value, or the FDA doesn't know how to assess. That's where a problem I had. So that would be my tip.
From a startup perspective, very pragmatic, acknowledging that this space is dry in terms of funding at the moment, also very promising. I would very specifically follow the money. The companies that we have, both in more of the medical side or even more of the consumer side, since we invest also in meditation, all these other tools, the ones that are successful are the ones who are able to monetize right now, to are able to show stickiness and adoption, and proxy in health. Money is a proxy of adoption in healthcare to understand what is the impact really. Are you creating a nice to have value? You mentioned earlier some of the companies that were just additive, adding to the workflow, but not were nice to have, not must have. So the one thing in mental health right now is the adoption, like the revenue, which is, if we can solve for revenue in the space, I believe you can solve for growth on the long term, but that's where I would start, like as a pre-series B companies, like focusing on this space.
Helen, what would it take for you to write a check?
Yeah, I almost would echo what Vic said verbatim, that if we look across our population of patients, the ones that appear to be struggling the most from a behavioral health standpoint are also struggling the most from a social determinants of health standpoint. And so acknowledging that those two are interlinked, and then treating these people holistically. So I don't have much more to add than what Vic said.
But one of the areas that we just have a couple minutes here, one of the areas that I just would touch on that at least we're seeing a little bit is the role of personalized genomics and how that will play in terms of these technology platforms and, medically, for the most part, outside of some specific ailments, medicating behavioral health issues is an art, not a science, and it's trial and error. And so I think, there are lots of inexpensive therapeutics that can be effective if you put them with the right patient and the right ailment, but we haven't really had a low-cost way to do that yet, and it's still very early, but at least we're starting to see a little bit there as well. We only have a couple minutes, but any questions out there that ask for the panelists? Yeah, go ahead.
I'm Leslie Shover from Houston. I think it's more of a comment than a question. I'm a psychologist, and for over 30 years we've had ecological momentary assessment, which is essentially how do you assess a behavior within its context in real time. And that used to be a big, major, difficult thing to do, and now it's so easy with smartphones. And I don't see it being used as much as it should be outside of research contexts. And the other thing that no one mentioned is I think the National Health Service in England is doing a lot better job than we are of democratizing mental health. And they have a whole low intensity cognitive behavioral step care system that is, I haven't looked at exactly how it's doing lately, but it sure looked a lot more promising than the way we allocate resources.
Yeah, the NHS has had its own share of fails in terms of trying to deploy apps at scale. And I do think, when you do have like a whole company or a whole healthcare system that you can require to use, it does provide an interesting test of that. I think Australia and some other places have also done a really impressive job that we would stand to kind of follow. I guess in addition to the EMA, which you mentioned, and there are some companies exploring that. I think combining that with what you can do with just passively sensing from devices now is really worlds away from, I think, given all the engagement issues. There's a lot of EMA type things, but people will use them once and then never again. So personally, I feel like we need to put a lot more thought into the digital biomarker side of the investment rather than digital health per se. I think there's the question of how do you know when someone's in need of services, and then what do you do when you figure that out? Those are two completely different arcs in my view, and like a psychiatrist, psychologist would treat them relatively differently in the kinds of system level things you would need, whether it's digital biomarkers pulling from people's internet traffic versus phone. Those are problems that I think technology is well suited to solve. I think figuring out what to do once you identify them, there are lots of ways you can ping them with apps, but I think that's a very untested space.
The only thing I would add to just that point about measurement, one of the biggest problems I have with measurement is a kid with autism had 8 different care providers: psychologist, neurologist, psychiatrist, teacher, ABA therapist, OT, speech language therapist, parent, and other family members. Each one would tell you a different thing that they wanted to see as the measurement outcome. And so the lack of agreement across the care provider is impossible. You can't go to somebody and say, this is a measure that is accepted.
Great. Well, we are at time, so I want to thank our panelists for their insightful commentary today and for your attendance, and that's it.